Howdy. Thanks for joining us and welcome back to the Hume Region series of deep dives into the provision of palliative care in aged care. And today we're looking at nausea and vomiting. So let's start by looking at the causes. As you can see, they are multiple, and as usual, it's pointless to try and address a troublesome symptom without first doing a thorough assessment to ascertain the cause with as much accuracy as possible. I say this because there are often times, especially with the aged care population, when a decision may be made not to investigate a complaint or symptom due to the stress it may cause, and instead we make a best guess. It's always worth bearing in mind whenever we're caring for the elderly that it's less of an exact science. So we need to bring all of our best skills of observation, assessment, and intuition to the table. The common causes are listed on this slide. In relation to palliative care, we'd be particularly interested in constipation or medicines, and also be on the lookout for a rogue infection such as a UTI or some middle ear disorder, which might confuse you. What I'm saying is, be careful not to jump to conclusions. Asking a lot of questions with aged care can be burdensome, but it's worth it. And hence, make your questions count and give plenty of time for the answers. And also, use your own observational skills and ask your colleagues to do the same, so that together you can build a clear picture of the problem. And don't forget to document. Nausea and vomiting are different and often have different mechanisms. Again, observe and document carefully, and those coming after you will thank you for it. These questions speak for themselves, I think. Now, the non-pharmacological management of nausea and vomiting is always worth giving a try. Things like guided imagery. You can use diversional tactics such as focusing on images and thoughts that they find pleasing or relaxing, sitting in an upright position and in a place with good ventilation or an open window and a comfortable, attractive environment free of triggering smells. I know this is hard to do sometimes in the aged care environment, but just make your best effort. Implement music listening in combination with guided imagery for optimal management of nausea and vomiting. You could try cognitive distraction that draws a patient's attention away from feelings of nausea and vomiting to things such as movies and television or arts and crafts or active music engagement. Acupressure. Now, how do you stop nausea fast with acupressure? You can look this up, Google it, I would recommend you. Sit down and place your hand on your kneecap. Press on the spot where your pinky finger is resting. The pressure point for nausea is located on the outside of your shin bone, just below the knee. Apply pressure in a downward motion and repeat on your other knee. So always worth trying. I might try that myself one day. Dietary considerations. Now, the following suggestions may be useful to help manage nausea and vomiting. So offer bland, dry foods such as toast and dry biscuits, or salty foods like chips or saltine biscuits. Offer smaller serves of food more frequently. And again, I know this is difficult in the aged care environment that's quite regulated, but it's important. Sucking on ice cubes, fizzy drinks such as soda water or dry ginger ale, and jellies can assist with an upset stomach. I know my mother used to give me barley sugars when I was unwell. Offer cold foods that have little smell, and eat meals in a well-ventilated room, clear the smells of food away. Okay, so now we go to the medications. So let's take a look at some of the common medicines used in palliative care to treat nausea. First up is haloperidol. Yes, I know, haloperidol is an antipsychotic, right? Well, yes, but many medications have dual effects, and this is one of them. It's particularly useful in palliative care precisely because of this effect, since those approaching the end of life can have deranged hemodynamics due to dehydration, excuse me, poor nutrition, and changed mobility status, as well as any disease process that is occurring. Haloperidol can treat nausea and vomiting, hallucinations, and agitation. I encourage you to explore its property further in whatever resource you have handy, such as the MIMS online or your textbooks. Now, of course, there are side effects. Use haloperidol with care and be aware of its interactions. My quick internet search revealed this little nugget. It also has been flagged to be used in caution with certain diseases such as dementia, Parkinson's, and hypothyroidism, but concerns such as these diminish during end-of-life care. However, be on the lookout for any delirium or increased agitation. We don't want our attempts to make the person comfortable backfiring and causing them greater distress. So good old Maxilon's the next one. An oldie but a goodie, I say. Medicalopromide has been used successfully to treat nausea for a while now. It's easy to give orally, subcut, IM, IV, so it's easy to keep using the same drug across time and changing status. It's best given around the clock if nausea is an ongoing issue. It's a favourite for use in the subcut infusion, like in the Nicky pump, as it is also compatible with many other medications. And again, I encourage you to check out these drugs, get yourself familiar with their side effects and their causes. Now, Medicalopromide side effects and drug interactions. I've been nursing for a very long time now, and I've never forgotten my training in my first year when they taught us about tardive dyskinesia as an adverse effect of the overdose of this drug. And while it's rare, it's always worth keeping in mind. The mechanism of action of metoclopramide is an increase in motility of the gut. Hence, it mustn't be used, must never be given if your resident has a complete bowel obstruction, because you'll only make everything worse, especially the pain. There's all its interactions. And again, these slides are only a point you in the right direction, make you aware. You need to go off and get yourself up to speed with all of these medications. Ondansetron. Now, this medication is used alone or with other meds to prevent nausea and vomiting caused by cancer drug treatment and radiation therapy or after surgery. So it's not used widely in palliative care. It has a different mechanism of action. It blocks one of the body's natural substance, serotonin, that causes nausea and vomiting. It may cause side effects. Tell your doctor if you have any of these symptoms. Headache, constipation, weakness, tiredness, chills, or drowsiness. It's not indicated for long-standing nausea or recommended as a standard antiemetic in palliative care. So if the doctor has prescribed ondansetron, maybe get a little bit of evidence behind you and present a case for maybe switching to metoclopramide. Unless, of course, your patient has a total bowel obstruction. And then, even then, you may be choosing haloperidol instead. Dexamethasone. Corticosteroids are naturally produced by the adrenal gland in the body. They influence the functioning of most of the body's systems, as we know, heart, immune system, muscles and bones, endocrine and nervous system. So it's a very powerful drug, dexamethasone. It exerts a wide array of effects, including on the metabolism of carbohydrates, proteins and fats. It helps to maintain the balance of fluids and electrolytes and prevents the release of substances in the body that cause inflammation. And as such, it's used to treat many different inflammatory conditions and is often the first-line drug for cerebral edema. It's very useful for those approaching the end of life to manage symptoms such as confusion, headache, and other neurological dysfunction, and pain from edema caused by tumours in spine and bone. It has the added effect of relieving nausea caused by cerebral edema, as well as gut blockages. Now, there's a whole bunch of common side effects that I suggest you look up. Dex may be a drug you encounter regularly in your work in aged care, so it's best if you do some research on it. And just a few cautionary notes. Steroid withdrawal syndrome. You need to be careful if your patient has been on a steroid, such as Dex or prednisolone, that it's not stopped straight away. And I'm pretty sure every GP on the planet is pretty aware of that. But you never know. You've got to be on the lookout for it. Long-term use of Dex is not recommended, as long-term steroids can suppress the protective role of your immune system And we already know that our aged care population has a weakened immune system to begin with in general. It can increase the risk of infection, increase risk of developing ulcers, GI bleeding, thinning of bones, and hence the increased risk of bone fractures. So the side effects of long-term steroid use are far-reaching and often significant. So it's not a drug to be considered lightly. It can cause effects such as elevated or depressed mood, fluid retention, high blood pressure, insomnia, elevated blood sugars, bone thinning, increased risk of fractures and glaucoma. So, yeah, tread lightly with this one, but in a short-term use, it's fantastic. Lorazepam is also a drug that's been used as a sedative, anti-anxiety, and lorazepam is used because it tends to be metabolized more rapidly than many other benzos, the benzodiazepines. It's mainly used for the short-term relief of symptoms of anxiety associated with depression, and it's been used to treat insomnia, nausea, and vomiting. So lorazepam was evaluated as an adjunct medication for the prevention of chemo-induced nausea and vomiting in patients with cancer. And it has been studied for its efficacy in the prevention of anticipatory chemo-induced nausea and vomiting. Use in the elderly could be limited given their vulnerability to falls and delirium. So again, every drug that we reach for has to be given with caution. Chlorpromazine is another powerful antipsychotic medication that can be used to control nausea and vomiting, and especially hiccups. So if you have a patient that's got some kind of diaphragmatic irritation, maybe from a space-occupying lesion in the gut, they may be getting regular hiccups. So chlorpromazine is a great drug for that. And again, caution required in the elderly. Any antipsychotics, anything that starts messing around with brain function is going to need a bit of caution. Cyclizine is a histamine H1 receptor antagonist with anti-muscarinic and antiemetic properties. So cyclizine reduces the excitability of the inner ear labyrinth and acts directly on the vomiting center in the brainstem. It has its uses in palliative care, as it can be used in a syringe driver. But there are limitations around compatibility, so make sure you've explored these before you use it. And there endeth the lesson. I hope you've gained something from this video. If you enjoyed it, please tell your colleagues. If you didn't, please tell us, and we'll see you in the next video.